to the third webinar in our Healthy Estrogen Metabolism program with Jo Gamble. My name is Gemma and I'll be here for the duration of the webinar to help with any queries or problems. As usual, please feel free to use the chat tool which is located in the bottom right hand corner of the screen to ask any questions. You can make questions or comments at any point over the course of the webinar and we will go through them all at the end. And I'll hand you over to Jo.
Good morning, everybody. Welcome to our third webinar in our Estrogen Metabolism program. We're back to a Monday morning, full of spring air out there, and I, for one, am very happy that I'm part of this program and ready to move forward. So, last time when I delivered a program to you, I was told that when I handed in my slide deck at 97 slides, I would never get it done in an hour. So this time I handed in a slide deck of 107 slides, and now I have to still try and get it in within the hour. So let's get ready to go. So what are we going to be covering this week? Well, actually, the majority of the work that we're covering is all on pathophysiology. Because last week what we did is we looked at genes associated with estrogen metabolism. We looked at the importance of addressing female hormones. But what's really important to know is what can go wrong with female physiology in order for us to be thinking about putting our clients on a program such as this, possibly with additional support alongside it if they've got that additional need. The conditions that we're going to be covering this week are thinking about premenstrual tension, fibrocystic breasts, polycystic ovarian syndrome, endometriosis, fibroids, and of course the menopause. So, during her menstruating life, a woman will have 300 to 400 menstrual cycles. That's a lot of periods during our lives. So therefore, there's a lot of opportunity during our lives for this to go wrong. So if we think about menstrual irregularities, so let's start with painful periods, otherwise known as dysmenorrhea. It usually occurs just before or after the onset of menstruation and can be a primary or a secondary cause. Heavy periods, menorrhagia, is a blood loss of over 80 mL for a menstrual flow lasting over 7 days, constitutes menorrhagia. Don't forget when you're speaking to your clients about heavy periods is don't ever accept the word it's normal, because actually what does normal mean? Ask them with regards to how often do they have to change their pad or their tampon. If they stand up, are they flooding? So, you know, I've got a client that I'm thinking of here who has to wear 4 pads at one time to prevent her from flooding. That, in my opinion, is heavy. So, you know, 80 mL is quite a significant amount of blood loss. Irregular periods. So any variation in cycle length plus or minus more than 4 days. If we're thinking sort of 28 days plus or minus 4 days would make us think that they've got irregular periods. So let's first of all think about premenstrual syndrome. Premenstrual syndrome is characterized by emotional and physical symptoms that consistently occur during the luteal phase of the menstrual cycle. The disorder can manifest with a wide variety of symptoms, including depression, mood lability, abnormal pain, breast tenderness, headache, and fatigue. I remember I told you this, I can't remember now if it was webinar 1 or webinar 2, any amount of breast tenderness is a sign that there's some imbalance going on with the estrogen, because we shouldn't experience breast tenderness. Now, 85% of menstruating women experience one or more symptom of PMS. 5 to 10% of women have symptoms severe enough to be debilitating. PMS affects women of all cultures and socioeconomic levels. More than 200 symptoms have been associated with PMS. Now, I know that sometimes we can blame our symptoms on PMS. You know, it's quite a good excuse, isn't it? You know, I'm feeling grumpy today, or it's your periods. Just like some men can blame us being grumpy when actually we want them to do something. Oh, it's that time of the month again, isn't it? But again, there's a massive divergence of symptoms from feeling maybe a little bit emotional, a little bit angry, to some people sort of taking to their bed for 2 weeks prior to their periods and lasting for 2 weeks. So what I've done in this table is I've put you together the physical discomforts and look at how they can affect us. So let's look at the etiology. Well, it remains unknown and it may be complex and multifactorial. There are no lab tests to confirm diagnosis, so therefore we have to look at, you know, symptoms. Some health conditions manifest symptoms similar to PMS, so that could include premature menopause or perimenopause, endometriosis, IBS, chronic fatigue syndrome, hypothyroidism, and major depression. Deficiencies in prostaglandins, and also some genetic factors. So, functional medicine considerations. And remember, this is where we want to go. This is where we want to take it. Functional medicine is just about digging down deep. Get your spade out and look right down deep. Look at the underlying mechanisms and think about the systems being affected at this stage. And remember, the key to hormones is balance. And hormones interact with each other. So if we think about progesterone deficiency or estrogen excess, what are some of the symptoms that you might see? Well, they're your premenstrual breast swelling, which in some people start at ovulation and go right through to menses. Premenstrual menstrual abdominal bloating, again, could be 2 weeks in some individuals. Irritability and anxiety, cystic breasts, mastalgia, menorrhagia, dysmenorrhea, so we've already covered these terms at the beginning, endometriosis, ovarian cysts, uterine fibroids, infertility, breast and endometrial cancer, breast tenderness, fat distribution in your hips or your thighs, and remember that's a good reason why it's important to do waist to hip ratio of your clients, and anxiety. So some of these symptoms might be short-lived, like breast tenderness for a couple of days before your period, but some of them can be, chronic, ongoing conditions. Possible causes of high estrogen include perimenopause, so the initial stage before they go into the menopause where, of course, that estrogen drops down low. Poor diet, e.g. high sat fats, which encourages growth of intestinal bacteria, which produces beta-glucuronidase. We've covered this, which shears off the glucuronic acid molecule, which prevents the estrogens being taxed out of the body, which results in recirculation of those estrogens. Estrogen E2 or E1 or androgen supplements. So, if anybody's on any form of either hormone support or bioidentical hormones also. Decreased hepatic clearance of estrogen, so thinking about the liver. High intestinal beta-glucuronidase, we just covered that. High BMI, so therefore that adipose tissue, especially that fat, it's producing its own estrogen. Hypothyroidism, smoking, it can raise our E2 levels. Certain medications, particularly tamoxifen, which is obviously a drug of choice post-estrogen positive breast cancer. Inflammation, those inflammatory cytokines can increase the conversion of estrogens. Possible causes of low progesterone include adrenal insufficiency, so think about the pregnenolone steal, and low cholesterol. So if somebody's on statins, again, it's going to drop their cholesterol level, which is going to reduce the conversion to pregnenolone, which is going to reduce the sort of precursors to the production of the progesterones. So if we're thinking about PMS, think about your antecedents and your triggers. So possible antecedents can include a family history, CYP450 SNPs, and we covered those last week, and a COMT slit, which is in your phase 2 liver detoxification, such as catechol O-methyltransferase, a poor diet, lack of exercise, and vitamin and mineral deficiency, which again can come from either a poor diet or poor absorption. Are we able to absorb the foods that we're eating? And then triggers can include the nutrient-poor diet, stressful life, and a lack of exercise. So here's just an overview of contributing factors in painful periods. Can include vasoconstriction, endometriosis, which we're going to cover, fibroids, which we're going to cover, copper coil, smoking, and excessive prostaglandins. And then factors in heavy periods include thyroid imbalance, stress, nutrient deficiency, especially iron, excess PG2, fibroids, endometriosis, clotting abnormalities, von Willebrand's disease, cancer, IUD, onset of menopause, and estrogen-progesterone imbalance, which we've covered those sort of factors. And then we've got, which is in a really bad colour, Joe. I think I need to change the colour of this because even I'm struggling to read it. Contributing factors in irregular periods, which includes thyroid imbalance, stress, polycystic ovarian syndrome, which we're going to cover again, endometriosis, fibroids, ovarian cysts, change in body weight, eating disorders, so anorexia nervosa, bulimia nervosa, binge eating disorder, excess exercise, alcoholism, and onset of menopause, as well, of course, as estrogen-progesterone imbalance. So, effects of organochlorine compounds on our menstrual cycles. Let's think about those toxins that so many of our clients take in their body, and hopefully during the last, 11 days, you've really been thinking about reducing your plastics, using a stainless steel water bottle instead of a plastic bottle, using a glass container to carry your food around, thinking about your beauty products, your shampoos, your conditioners, thinking about what you wash, your clothes in and do your washing up with. So the study results indicate an effect of DDT exposure in ovarian function and menstrual cycle length. These effects could cause problems with fertility, pregnancy, or adverse reproductive conditions. So, these are studies that are showing that these chemicals that some people don't even consider actually can cause long-term damage. So let's have a look at fibrocystic breast disease. It's getting more and more common. Why is it more and more common? Because of the exogenous estrogens that people are taking on board. So it's characterized by cyclical, bilateral, multiple cysts in the breast, often accompanied by premenopausal breast pain, swelling, and tenderness. During the menstrual cycle, female hormones cause breast tissue to proliferate in preparation for pregnancy. This causes a feeling of fullness in the breast. When menstruation takes place, these tissues undergo destruction of the excess cells that have accumulated within the breast. If the unneeded tissue is not effectively cleared from the breast, then fibrous and cystic changes can occur. Estrogen dominance leads to hyperproliferation of breast tissue, poor estrogen metabolism and excretion, corpus luteum deficiency, anovulation, and the pregnenolone steal. So these are all potentially contributing factors. Low thyroid function, so suboptimal levels of thyroid hormone sensitize breast tissue to the effect of prolactin. Also iodine deficiency, which could be the driver of the low thyroid function. Increased levels of prolactin, so possible to link to low thyroid and or estrogen dominance. So if you're suspecting in one of your clients that they may be deficient in something like iodine, you can actually do an iodine skin test with Lugol's iodine, 3% solution, and you just paint that onto their skin and see how long it takes for their body to absorb it. Or you could also do a full thyroid plus test, which looks at all areas. Remember, TSH is not a purely diagnostic criteria even for a doctor to make a diagnosis of hyperthyroidism. People can have a normal TSH and still be subclinically hyperthyroid. So if you're suspecting this, then most definitely send them off for some lab tests. Methylxanthins. Consumption of coffee, chocolate, and other methylxanthin foods has been positively associated with fibrocystic breast disease, stress, pregnenolone steal, increased aldosterone leading to water retention, suppression of thyroid activity, and linked to increased prolactin levels. Do you need to send your client off for an adrenal stress test? Isoflavones. Epidemiological studies show that isoflavone exposure is inversely related to fibrocystic breast disease. In addition, a double-blind placebo-controlled randomized trial has shown that both 40 and 80 milligram doses of isoflavones are more effective than placebo in reducing cyclical breast pain. Now, we've definitely got those isoflavones within this program. So if you've got that client out there with those fibrocystic breasts, then definitely this is a program for them. Methylxanthines, coffee, chocolate, tea, soft drinks, wine, beer, and some over-the-counter medications contain caffeine or other similar compounds. Methylxanthines can contribute to the development of fibrocystic breast disease. Reducing or eliminating these foods and drinks may reduce breast symptoms. Well, of course, we've not got those in our program. Many women experience premenstrual water retention, which can worsen breast swelling and pain. Key strategies to manage this include reducing salt intake, optimizing magnesium status, maybe you need to put them on an extra magnesium product, reducing intake of stimulants, reducing stress, and including natural diuretic foods, of which there's many available to us. Now let's go on to PCOS. Now, diagnosis of PCOS. So in 2004, the Rotterdam Consensus agreed the following criteria for diagnosis of PCOS, and that is a client should have 2 of the following 3 cycles: oligo and or anovulation, clinical or biochemical signs of hyperandrogenism, so thinking about, adult onset acne and facial hair, and polycystic ovaries on ultrasounds or direct inspections. These are those like pearl-like cysts, small but multiple cysts. And then exclusion of hyperprolactinemia, thyroid disorders, and other causes of hyperandrogenism. So, key features: increase in gonadotrophin-releasing hormone, pulse frequency, increases production of luteinizing hormone, reduction in follicle-stimulating hormone production, excess production of androgens, so therefore you're thinking that their free testosterone level is likely to be high, estrogen dominance, hyperinsulinemia, decreased levels of sex hormone binding globulins, therefore they're not got anything to bind, so they've got lots of free hormones. Elevated leptin and leptin resistance, so therefore we're thinking about, they're not listening to those signals of full and empty, and therefore they're more likely to end up with increased body weight and increase in 5-alpha reductase activity. And here's just a really nice diagram to talk you through the pathophysiology. So if you've got any clients that you can use that diagram with. Androgen excess can cause acne beyond puberty, hirsutism, male pattern baldness, voice deepening, weight gain, loss of female body contour, altered menstrual cycling, infertility, fatigue, mood swings and depression, increased libido in women, clitomegaly, so that's an enlarged clitoris, testicular atrophy, that's obviously in men, edema, liver disease or cancer, and reduced HDL cholesterol. So remember, there's a lot going on here. And insulin is a direct driver of increased androgen, so we definitely want to be thinking about balancing those blood sugars. And maybe your client needs the extra support of some factors that can help with blood sugar balance, like cinnamon, like chromium, like alpha-lipoic acid. So this is what I'm saying. We've got our core program, and then you need to be thinking of additional products that you might need to use alongside that. So then if we're thinking about genetics, polycystic ovary syndrome is a complex disorder in which a small number of key genes interact with environment factors, the balance of which determines disease outcomes. The condition is known to run in families, and several genes have been identified that are thought to influence PCOS susceptibility. These include genes involved in insulin signaling as well as androgen production and activity. So if we think about it from a stress point of view, some authors argue that stress may be an important precipitating factor in PCOS. Under stress, production of CRH increases, stimulation of the release of cortisol and androgens. The high cortisol then leads to elevated blood sugar levels and in turn excessive insulin secretion. Long term, the cocktail of cortisol and insulin can lead to further production of androgens, central adiposity, and the development of metabolic syndrome. So stress can exacerbate that central adiposity, increasing conversion of androgens to estrogen. The resulting estrogen dominance can then disrupt levels of gonadotrophin-releasing hormone, luteinizing hormone, and follicle-stimulating hormone. The elevated LH and low FSH further stimulates androgen production, eventually leading to virilization and menstrual irregularities. Now, we've already talked about contaminants with regards to fibrocystic disease, but it's also believed that those contaminants are directly linked to PCOS, particularly BPA. BPA levels were significantly higher in the total PCOS group compared with the controls. PCOS women, lean and overweight, had higher BPA level concentrates to the corresponding control group, lean and overweight women. A significant association of testosterone and androstenedione with BPA was observed. Multiple regression analysis for BPA showed significant correlation with the existence of PCOS. BPA was also positively correlated with insulin resistance in the PCOS group. Now, what we don't know at this stage is whether the BPA was the driver of PCOS or whether there is a different involvement with regards to things like liver detoxification in clients with polycystic ovarian syndrome, which is preventing the detoxification of these excess chemicals. So symptoms include oligomenorrhea, so varying from a regular but elongated cycle with periods every 6 weeks or so through to irregular periods occurring just once or twice a year, related to abnormal follicle development and anovulation due to disturbances in the production of hormones. This is thought to be exacerbated by luteinizing hormone, hypersecretion, hyperinsulinemia, and the resulting increased levels of androgens. It's speculated that aberrant signaling by anti-Mullerian hormone and bone morphogenic proteins, which inhibit follicle-stimulating hormone sensitivity, may also contribute to the aberrant follicle development. So we're now seeing that it's very complex. Symptoms also include infertility, so anovulation, infertility due to arrested folliculogenesis is common in PCOS sufferers, frequently found to be associated with obesity and insulin resistance. More risk of miscarriage, more common in PCOS sufferers and related to high levels of luteinizing hormones and androgens. A series of intra-ovulation growth factors seems to act together in a process that triggers anovulation or early pregnancy loss in PCOS, though it's not yet clear whether this is cause or an effect. And remember, guys, this evidence is, is constantly evolving. We're constantly learning new things. Further symptoms include obesity. It may be the cause or it may be the effect and related to insulin resistance. Acne, this usually appears on the face, typically affecting the jawline, but may also occur on the back and chest. It occurs as a result of sebaceous gland stimulation by excess androgens. Acanthosis nigricans, a skin disorder in which there's darker, thick, velvety skin in body folds and creases associated with insulin resistance. So sometimes you might see this sort of in the fat layers within the neck, underneath the armpits, or in fat layers on the back. Hirsutism, which is excess growth of facial and or body hair in a male distribution pattern. This is a result of increased androgen levels. Stimulation of 5-alpha reductase by high insulin levels can also contribute. Androgenic alopecia, so male pattern baldness. Excess androgens, especially DHT, are the main cause. So you might see women with thinning on the top of their hair. Health effects. The hormone and metabolic imbalances in PCOS predispose sufferers to a number of health problems, including metabolic syndrome, high CRP levels, so C-reactive protein, so thinking of an inflammatory response, high homocysteine levels, so then you're thinking about methylation. So think back to what we talked about last time and think about, are they methylating their estrogens, and definitely are they at more risk of cardiovascular disease, type 2 diabetes, endometrial cancer, depression and anxiety. And I think the anxiety is something to be very conscious of. If a lady's got facial hair, it can definitely have a lowering of her self-esteem. And again, another diagram for you to take a look through. PCOS is associated with a low grade of chronic inflammation. So remember, chronic is just ongoing. Inflammation is not a bad thing. What's bad is the perpetual cycle of inflammation. So even low grade, it's when it becomes chronic, then that is detrimental to the body. Mainly associated with the accumulation of visceral fat. And remember that fat produces its own inflammatory cytokines. Adipose tissue secretes various inflammatory messages and adipokines that can influence the development of insulin resistance, dyslipidemia, and endothelial dysfunction and metabolic and cardiovascular long-term complications. What more, by stimulating androgen synthesis, these inflammatory mediators also seem able to contribute to the maintenance of the syndrome. And here's just a diagram for you looking at all of the different systems affected and perpetuated by this inflammatory response. And then we've got oxidative stress. A number of studies also indicate that PCOS is associated with increased levels of oxidative stress. This may even be present in the absence of metabolic syndrome or insulin resistance. So these clients may need the additional support of increased antioxidants. Studies show that loss of intra-abdominal fat is associated with resumption of ovulation in women with PCOS. Weight loss also improves insulin sensitivity and lowers cardiovascular risk. So we definitely want to be thinking about encouraging them to, dietary changes, lifestyle changes to get that fat moving. Low GI diet. In a recent study, a low GI diet was found to improve insulin sensitivity and menstrual regularity more effectively than a macronutrient-matched normal health diet in a group of women with PCOS. And what we've got provided is that low GI diet. And here's a study for you on the effect of a low glycemic index diet compared with a conventionally healthy diet on polycystic ovary syndrome. So, there are published studies out there, and this might give you more weighting when you're working with a client. In a similar PCOS study, a high-protein, low-carbohydrate diet has been found to be more effective than a low-protein, high-carb diet for improving symptoms of depression and anxiety, reducing total cholesterol and raising HDL, your good cholesterol, and maintaining endocrine improvements during weight management. A recent Cochrane review has found that lifestyle interventions based on exercise with or without dietary interventions can improve body composition, hyperandrogenism, and insulin resistance in women with PCOS. There's also evidence from a small prospective study that aerobic exercise can improve insulin sensitivity and reduce the total number of follicles on the ovaries. So therefore, if we use the diet and the lifestyle simultaneously, then what benefits do you think we'll achieve? Hopefully a lot more. And then we've got our supplement regime on top of that. Exercise has also been shown to raise sex hormone binding globulin as well as lowering inflammation. So lots of positives there. Cinnamon extract can be shown to reduce insulin resistance by potentiating insulin action. In a recent trial, 15 women with PCOS were randomized to daily oral cinnamon or placebo for 8 weeks. Comparisons of post-treatment to baseline insulin sensitivity include using fasting and 2-hour oral glucose tolerance tests showed significant reductions in insulin resistance in the cinnamon group, but not in the placebo group. So, use our product that's got a good therapeutic dose of cinnamon and get them to use cinnamon in their daily regime also. In a 2005 trial, a 200 microgram per day dose of chromium piconolate was found to improve glucose tolerance compared with placebos in a group of women with PCOS. In a similar trial, chromium piconolate as a dose of 1,000 micrograms per day given without change in diet or activity level caused a 38% mean improvement in glucose disposal rate in 5 obese subjects. And then we've got our alpha-lipoic acid, so the third product that we've got in our synergistic blend. In a small open-label trial, 600 milligrams of alpha-lipoic acid was given twice daily for 16 weeks to a group of 5 non-diabetic patients with PCOS. At the end of 16 weeks, there was a 13.5% improvement in insulin sensitivity. There was also a lowering of triglyceride levels and a shift in the distribution of low-density lipoproteins towards the larger, more buoyant LDL subclass fraction. In addition, 2 of the subjects were not on an oral contraception, had an increased number of menstrual cycles. L-carnitine may be another product that you want to consider using. Carnitine plays essential roles in energy production, oxidative stress, and glucose metabolism. However, a 2008 study has been found that women with PCOS have significantly lower levels of carnitine than healthy women. This is thought to be associated with hyperandrogenism and or insulin resistance. Remember that carnitine is involved in taking the fat into the Krebs cycle and into the citric acid cycle for energy production. So if we've got a low carnitine issue, even if we're using fats like coconut oil, if we can't transport them into the Krebs cycle and the citric acid cycle, we're not going to produce good levels of cellular energy. In a study comparing the effect of muffa-rich almonds versus omega-3 and omega-6 puffer-rich walnuts on metabolic and endocrine parameters in PCOS, a daily portion of walnuts containing 31 grams of total fat per 6 weeks was found to increase the omega-3 to omega-6 ratio, decrease LDL by 6% and apoprotein B by 11%, increase insulin response during ODTT by 26%, increase adiponectin, decrease glycosylated hemoglobin, and increase sex hormone binding globulin. So, adding those in as an additional dietary recommendation may be really beneficial. Walnuts have also been shown to significantly lower diastolic blood pressure, total peripheral resistance, and flow-mediated dilation when used in place of other dietary fats. A low-carbohydrate diet supplemented with walnuts has also been shown to be more effective than a low-carbohydrate diet alone for reducing central adiposity in patients with metabolic syndrome. So lots of benefits there for adding those in. Omega-3, polyunsaturated fatty acids, particularly long-chain omega-3 puffers, are known to improve metabolic health. Data from a recent PCOS study has shown that a high omega-6 to omega-3 ratio is associated with higher circulating androgens. Plasma omega-3 status is associated with a less atherogenic lipid profile. And long-chain omega-3 puffer supplementation can reduce plasma testosterone concentrations. So definitely want to be considering putting these guys on a fish oil supplement. A similar study using 4 grams of fish oil for 8 weeks has shown that administration of omega-3 fatty acids can significantly decrease liver fat, so thinking about fatty liver, reduce triglycerides, reduce blood pressure. And then vitamin D. In a recent study looking at vitamin D levels in PCOS sufferers in Scotland, 72% of subjects were found to be vitamin D deficient. The result also showed that low vitamin D status was associated with high BMI, high C-reactive protein, higher levels of free androgens, reduced insulin sensitivity, low levels of HDL cholesterol, and lower levels of sex hormone binding globulin. So, in my clinic, I pretty much vitamin D test everybody that walks through the door. According to the National Diet and Nutrition Survey, 90% of the general population in the United Kingdom have insufficient blood levels of vitamin D, and 5 to 20% of the population are at a state of severe deficiency. So here are the reference ranges that you would be thinking about with regards to getting your client to sort of a sufficient amount of vitamin D. Make sure you don't go too high. I've just had one of my clients cause themselves vitamin D toxicity because they were self-prescribing it. And I've just put you in a research paper here showing a cost-effective method of correcting vitamin D deficiency and maintaining adequate levels is to give patients a 50,000 IU capsule of vitamin D once a week for 8 weeks. Obviously, I would only use at this dose if I'd already checked their vitamin D level, so you can do their vitamin D, use the intervention, and then retest them after 8 weeks. You can get vitamin D tests for £25. It's a really cheap way to, get your clients to that optimal level. Bonus here is they don't have to remember it each day, so get them to dedicate a D day. So it might be a weekend day if they're off work, or it might be a work day when they're feeling more in the zone, and then that's the day where they have their 50,000 IU. So now let's moving on to endometriosis. Endometriosis is a condition where the cells, like the ones in the lining of the womb, are found elsewhere in the body. According to Endometriosis UK, it affects approximately 2 million women in the UK. Unlike a menstrual bleed, which has a clear passage out of the body, the blood released from the endometriosis cells is trapped. This means when the cells bleed each month, inflammation and pain occur. In long term, this can lead to scar tissue and adhesions forming. I've got a client that's actually got adhesions all over her ovaries and the outside of her womb. And what happened was she went into labour, and every time she had a contraction, it was almost trying to tear the adhesions off the tissue on the outside of her womb. She was in the most pain. She said she actually said, if I was given the option, I would just die to get out of this amount of pain. And after about 4 hours, they realised what was going on, and they took her in for emergency cesarean section. And she was a real mess when they got her into there. So, it can cause lots of problems. Endometriosis deposits are most commonly found in locations such as on the ovary, where they form chocolate cysts. They're very different in presentation to the PCOS cysts that we talked about. Inside the pelvis in the fallopian tubes, on the outside of the womb, or on ligaments which hold the womb in place. It can also occur in the bladder, the intestines, the vagina, and the rectum. Has even been found in more distant places such as the joints and the lungs. I've got a client with it on her lungs. The symptoms of endometriosis can vary a lot between individuals. Some women have endometriosis without experiencing any symptoms at all. Most common symptoms include pelvic pain before and during periods, pain during sex, irregular bleeding or heavy bleeding, painful bloody bowel movements during menstruation, painful bloody urination during menstruation, swelling in the lower abdomen, extreme tiredness, and fertility problems. So what causes it? Well, there's 3 main theories: retrograde menstruation with transplantation, so instead of blood loss going out, it's going back up into the body, metaplasia, and developmentally misplaced endometrial tissue. So estrogen-progesterone imbalance, endometriotic lesions show high estradiol biosynthesis and low estradiol inactivation compared with normal endometrium. Enzyme expression studies have revealed that endometrial deposits have significantly upregulation of the enzymes involved in estradiol formation and in progesterone inactivity. Inflammation is a massive driver or perpetuator, so steroidonic acute regulatory protein and aromatase are both essential for estradiol production. PGE2 is a potent known stimulator of both STAR and aromatase. PGE2 production in endometriosis is upregulated by increased levels of the enzyme COX-2 in the tissue. COX-2 in turn is stimulated by estradiol, interleukin-1 beta, and PGE2. This creates a vicious cycle that favors continuous formation of estradiol and PGE2. Xenobiotics, another chemical group that another condition that we're associated with external chemicals being taken into our bodies. So studies in mice have shown that prenatal exposure to BPA elicits an endometrius-like phenotype. In human studies, serum levels of dioxins seem unrelated to endometriosis, but a recent study has found that higher levels of dioxin in perinatal fluid were significantly associated with an increased risk of the disease. So again, this is why we need to educate everybody to be able to stop using these chemicals. Dioxin and dioxin-like compounds may also affect the pathophysiology of the endometriosis by altering the expression of cytokines, growth factors, and remodeling enzymes. This is likely to alter PGE2 levels, which in turn is linked to increased aromatase expression and increased local estrogen production, as well as local inflammation, all of which contribute to increased cell viability, proliferation, adhesion formation, neovascular, and pain. And here's just another diagram for you. Endometriosis is associated with increased secretion of pro-inflammatory cytokines, neoangiogenesis, abnormalities in programmed cell death, and immunosurveillance of endometrial cells, changes in the expression of certain adhesions and invasion factors inside the endometrial cells, and dysfunction of immune processes. In particular, macrophage numbers and activity are enhanced, NF-kappa B is activated, numbers of mature antigen-presenting cells are decreased, natural killer cells and cytotoxic T cells display reduced cytotoxic activity, autoantibodies are produced by B lymphocytes, T regulatory cells function is increased, resulting in suppression of immune responses. Autoimmunity. Endometriosis is also considered to be an autoimmune disease because it fulfills most of the classification criteria for such diseases. Specifically, it presents with tissue damage, production of autoantibodies associated with other autoimmune diseases. These anti-endometrial antibodies might be partially responsible for failure of implantation leading to infertility. I just caught a question that came in then from Kate about would it show up in the bloods. Actually, this is an antibody that you can pick up in the blood test, anti-endometrial autoantibodies, as well as looking at raised inflammatory cytokines, CRP, ESR, etc. So hopefully that answers your question because it was just a natural case. Some authors suggest that reduced NK activity could explain the increased autoimmune reactivity associated with the disease. In the perinatal cavity, natural killer cells might be less effective in killing antigen-presenting cells, facilitating their presentation to autoreactive T cells and the production of autoantibodies. It's been shown that women with endometriosis diverge in their expression of several genes which might be involved in the processes of hormonal balance, immunity, and inflammation. Some of these differences may be rooted in genetics, whereas others may be epigenetics. Remember, your epigenetics are the marking of your genes. And although last week we actually covered sort of the profiles of the genome detox profile, and then I added in MTHFR looking at the C677T SNP, you can also look at a immunogenomic, that's the one, and that will also look at things like all of your interleukins and inflammation within your interleukins. So that looks at your genetic predisposition to inflammation. Other dietary analyses have shown that a high intake of omega-3 is associated with lower endometriosis risk, with a high intake of trans fat increases disease risk. In addition, endometriosis seems to be associated with celiac disease, which is, of course, another autoimmune disease. Now, when somebody's got one autoimmune disease, they are at more risk of others, and I've got some clients that have got 5 or 6. Potential explanations include shared etiological factors and celiac disease-mediated inflammation. Some nutritionists who specialize in endometriosis find that a gluten-free diet can decrease the pain experienced by endometriosis sufferers, as well as improving their fertility. So don't be afraid to try them on a gluten-free diet, even if they don't have celiac disease. And remember, tissue transglutaminase is only one route of testing, and often can be false negative in people. The reason it can be false negative is because people are born, it's believed about 30% have a genetically low secretory IgA. And actually what they're testing is IgA, TTG. So if you have a genetically low IgA, you're likely to get a false negative. And I've actually got a celiac client who had 5 TTGs, all negative. She was so symptomatic of celiac disease, and it was only when her mum begged them to biopsy her that they found that the villi had been destroyed, and she did in fact have celiac disease. So remember, it's not conclusive. But even when they're not, I use gluten-free diets for pretty much all of my autoimmune clients, as long as they're prepared to stick with it, and it really does have a positive impact on their autoantibodies. Oxidative stress has been identified in the peritoneal fluid and peripheral blood of women with endometriosis. Women with endometriosis have also shown to have lower antioxidant status and healthy controls, despite similar dietary intake. So therefore, their need is even bigger. However, studies show that implementing a high antioxidant diet reduces oxidative stress markers and increases antioxidant markers. There's also evidence that supplementation with vitamin C and E can lower oxidative stress markers in women with endometriosis. So maybe this is extra support that you want to give to your clients with endometriosis. Dietary therapy with antioxidants is being recognized as a useful strategy for improving the function of the immune system, fighting free radical damage and managing chronic pelvic pain. So, again, maybe look at our synergistic blend of antioxidants, either our plant-based antioxidants for vegetarian or vegan clients, or our green tea, lycopene and limonene product. But it is in a gelatin capsule, so that's why I gave you an alternative for vegan clients. We've already seen that higher dietary intake of omega-3 is associated with lower endometriosis risk. What's more, animal model studies show that EPA supplementation reduces the thickening of the intestinal and active site for inflammation in endometriosis, as well as providing the levels of inflammatory cytokines, prostaglandins, and NF-kappa B. This suggests fish oil supplementation may be a valid anti-inflammatory strategy in endometriosis. So again, another add-on you want to put to the program. Moving on to fibroids. Well, fibroids are benign tumours that originate from the smooth muscle cells of the uterus. These tumours range in size and may be solitary or multiple. So when they range in size, currently I've got a client who is supposedly having surgery to remove a 16 centimetre tumour that is the fibroid. So that's a big fibroid that's going to be cut out. Her tummy is very tender to the touch because, of course, it's so swollen. As fibroids grow and develop, they can cause distortions in the surrounding tissue and organs, bleeding, tissue, death, calcification, and cysts. So symptoms include fibroids are often asymptomatic until they're large, at which point they can cause abnormal bleeding, heavy or painful periods, abdominal discomfort and bloating, pain with bowel movements, disturbances in urinary habits. If it's swelling into the urethra, then it's definitely going to cause disturbance, pain during intercourse, backache, and fertility issues. Risk factors include African American race or ethnicity, early menarche, so early starting of periods, HRT or OCP use, family history of fibroids, high blood pressure, remodeling effects, and obesity. Consumption of red and processed meats, high glycemic index diet, drinking alcohol, and history of pelvic infections. So the exact cause of fibroids is unknown, but hormonal, genetic, and growth factor interactions are known to play a role. Hereditary genetic susceptibility as well as genetic mutations are thought to be implicated in fibroid tumorigenesis, while estrogen and progesterone are important promoters of fibroid growth. Like endometriosis, fibroids are another abnormal cell type capable of upregulating estrogen in a local environment. These are known to express higher levels of aromatase and increased levels of estrogen receptors. In addition, progesterone is also thought to promote growth of fibroids by increasing the production of growth factors and decreasing the production of factors that regulate apoptosis. There's also suggestion that progesterone may mediate fibroid sensitivity to estrogen by upregulating estrogen receptors. I've got a client that's prescribed herself progesterone cream, and she doubled the size of her fibroids within a month from giving her that. Growth hormone, leptin, and prolactin are also thought to play a role in fibroid growth, but their role is less well defined. Interesting reports have begun to appear that also point to the ability of certain xenoestrogens to upregulate estrogen receptor transcription and expression in fibroids. Like in endometriosis, uterine fibroids are associated with increased levels of inflammation and oxidative stress, as well as compromised antioxidant status. Increases in oxidative stress may also be mediated by excess estrogen increasing nitric oxide production. Lab and animal studies show that EGCG, so the extract in green tea, and curcumin, the active in turmeric, are also able to inhibit the proliferation of fibroid cells and induce apoptosis. So we've got both those going in through our diet, and again, you could look at additional supplementation. There's also evidence that plasma selenium levels may be lower in women with fibroids, and that levels of selenium binding protein 1 are significantly lower in fibroids than in normal myometrium. This ties in with an animal study which showed that tumour size in selenium-fed quails are smaller than those found in control birds. Vitamin D. A number of lab studies also indicate that vitamin D can inhibit proliferation of human uterine cells. This is thought to be mediated via inhibitory effects of vitamin D on COMT involved in estrogen metabolism, and TGF-beta3 upregulates synthesis of many of extracellular matrix proteins that are associated with tissue fibroids. This suggests hypovitamin D can be a contributing factor in fibroid development and progression. So the menopause, moving on to the menopause. Menopause is the permanent end of menstruation, or defined as cessation of periods for 12 straight months without other obvious causes. Now, what you need to remember is a natural menopause is not a disease state. Natural menopause is a normal state. And what I'm referring to as a natural is as averse to a surgical induced menopause, which is when somebody's had a hysterectomy and their ovaries removed. Now, that is very abrupt on the body and can cause many side effects. Because the body's gone from having usually very high levels of estrogen, because many of the reasons why people have a hysterectomy is due to conditions that we've talked about, so fibroids or endometriosis. So then they have their womb and possibly their ovaries, or of course endometrial ovarian cancer. So they've gone from having high levels of hormones to a very abrupt drop overnight. So average age for the menopause is 51 plus or minus 5 years. Blood testing can include looking at your estradiol levels, FSH levels, and luteinizing hormone levels. So what happens at approximately age 40 to 50, the pool of remaining ovarian follicles become exhausted. Eggs are no longer being matured and ovulation ceases. As a consequence, the ovaries fail to produce estrogen and progesterone, and the feedback loop to the pituitary is disturbed. This causes levels of gonadotropin-releasing hormone, follicle-stimulating hormone, and luteinizing hormones to rise. Bursts of GnRH from the pituitary and changes in levels of estrogen and progesterone are thought to be the cause of menopausal symptoms in many women. Menopausal women also typically experience a decline in testosterone. This decline is thought to be largely responsible for diminishing libido and loss of sexual response that can occur at the time of life. Ironically, the reduced estrogen levels in postmenopausal women cause a relatively higher concentration of circulating testosterone. This relative elevation in testosterone levels can increase LDL levels and lower HDL. Did I just do two slides then? No, I didn't. I thought I did. So symptoms can include hot flushes, night sweats, insomnia, mood swings, depression, vaginal dryness and atrophy of the vaginal lining. I've got a client at the moment who's she had a surgical menopause. She's got such horrendous vaginal atrophy that she's just bleeding continually, and she keeps picking up infections because she doesn't have the mucus down there to keep her hygienic. Dry skin, skin thinning, weight gain, fatigue, memory loss, muscle pains, hair loss, shrinkage of the breasts, headaches, and low libido. The adrenals are exhausted before the menopause. Production of progesterone, testosterone, and adrenal estrogen precursors will be compromised, but ovarian production of androgenic estrogen precursors will remain the same. If stress occurs during the menopause, progesterone can be diverted down the cortisol pathway rather than the DHEA pathway needed to make testosterone and estrogens. Both situations can lead to an imbalance between progesterone, testosterone, and estrogen at menopause. So therefore, stress is so important both before and during menstruation. This is what I always say to my clients when they're females that are very adrenally exhausted, that we need to replenish that adrenal bank account now, because you do need that in your later life. We do need it to protect us from things like osteoporosis. So that takes us on to looking at the bone health. Estrogens also plays an important role in bone health by decreasing the rate of bone resorption. As estrogen levels decline, the body's ability to keep up with the natural process of bone turnover also declines. As body mass decreases, the risk of fractures increase. Two meta-analyses examining the effects of soy isoflavones on body mineral density shows that isoflavones significantly attenuate bone loss of the spine in menopausal women. The effect was more pronounced when more than 90 milligrams a day of isoflavones were consumed. And remember, attitude is, significant. The impact of attitude towards the menopause on women's symptoms experience a systemic review. And the conclusion of this study was women with more negative attitudes towards the menopause in general report more symptoms during the menopausal transition. However, use of standardized culturally sensitivity, attitude, and specific symptom measurements are recommended in future studies. So basically, how you feel about going in the menopause can definitely have an impact on the symptoms that you experience. And remember, as long as you're breathing, it's never too late to start a new beginning. We all started a new beginning 11 days ago, and now I hope you're all thinking out there, which of your clients are now going to benefit from putting them through this estrogen detoxification program, supporting the clearance of their estrogens, whether it's for one of the conditions I've mentioned today, or another reason that you feel that they would benefit. So once again, I've managed to complete my deck with time left for questions. So back over to you, Jem.
Brilliant. Thanks, Jo, for a great webinar, really informative this morning. Yeah, there's some questions come in, so if I just jump back to the beginning. I'll go to that one at the end, actually, but okay. James has got a client, he says he's got a client post-op, revealed endometriosis and left fallopian tube released. Symptoms now are breast tenderness, lack of libido, abdominal discomfort, distended abdomen. Client had a C-section 15 months ago. Would you say this is excess estrogen imbalance, and what's the best test to diagnose this, do you think?
Yeah, definitely. There's still too much, it sounds like there's too much estrogen going on over there if she's still got that breast tenderness. I think I would look at doing the estrogen. What you want to look at is the ratios of estrogen. So she's already got endometriosis, that's right. So she had a C-section, so therefore I'm presuming that she's still, of relative age if she's just had a baby. She's therefore probably got, I'm guessing here, because obviously I don't know the case history, probably got a good number of years of menstrual cycles left. And if she's still experiencing these symptoms, again, I don't know. They said he said that she's released the fallopian tube. I don't know how much of the endometrial tissue they've taken away. I'm presuming there's still endometrial tissue there, and therefore I would definitely think about an estrogen metabolism plus. Look to see if she's methylating. Look at the levels of 2-hydroxy, 4-hydroxy, 16-alpha-hydroxy, and then 2 and 4-methoxy. And then I would definitely, this is the right program for her, probably with additional support of some fish oil, reduce inflammation, maybe something like some curcumin, again, reduce that inflammatory response that's going on. And then think about the bigger picture, James. Think about, what's going on with the gut. She's had a C-section. Sounds like she's had a second operation to have her fallopian tube released. So therefore, think of the toxicity that's gone into her body, presumably with at least one of those being general anesthesia. Maybe she had the other one done through, a spinal block. Think about analgesia that she's had going in there. So probably a lot of toxicity in there. Think about the health of the gut. Has she had many sets of antibiotics over her life? That bloating, is it endometrial linked to the endometriosis, or is it another factor? And do you need to consider doing, a 4 hours protocol with her?
That's brilliant. Thanks very much for that, Jo. Really helpful. A couple of questions on endometriosis sort of diagnosis. Someone's asking, is there like a Genova test that you could recommend, or is it basically a laparoscopy?
No, so you can get, there's not really a Genova test other than looking at, estrogen that's dominating it, perpetuating it. It is something that, you would more go down the line of a GP making that diagnostic, looking at antibodies, looking at ESR, erythema sedimentation rate, looking at C-reactive protein, try and get the doctor to do a vitamin D level as well, if they can't do it privately, and then, work with that. And then, usually it's a laparoscopy.
Brilliant. Thanks, Jo. I think this question is, why would you recommend a high dose of Vit D instead of a regular but lower dose?
Actually, there's quite a lot of research out there, and take a look at it. I just put one of the research papers in today that's showing that, because remember, it's a fat-soluble vitamin. It's not like, say, the B vitamins that in excess you just pass them, them down the toilet. This is a fat-soluble vitamin, which is why you have to be careful with toxicity. So my client that's managed to get themselves up to 500 nanomoles per litre and then phoned me up and said, I feel really sick. You do have to be a bit careful with it. But there is quite a lot of research and more of it happening that actually the efficacy of vitamin D supplementation is increased by supplementing it 1 day a week at high doses. And actually some of the research is going out there up to 80,000 IU 1 day a week.
Okay, brilliant. Thanks for that. Question come in. I'm guessing this is she says, will the current program support all of the above problems? I'm presuming we mean all the ones you've discussed today. Or do we need to add in omega-3s and Vit D, maybe magnesium?
Yeah, so what we've put together is what we call our core program. And remember, everybody is unique. So the core program is for all of the conditions and other things. Also you've got men on the program. And today, sorry guys, I just haven't had the chance to cover male physiology or pathophysiology. I've talked to personal trainers about using this for people who they're struggling to shift weight. So, there's a lot of men out there that are in a case of estrogen dominance. So this core program is kind of across the board. It's suitable for all of us. But then what you have to consider is there any additional support that you need to add in to that? So whether that is Vit D, whether it is fish oil, whether it is curcumin, whether it is myo-inositol, whether it is. And next week we will talk about, not about these conditions because that's what I've covered today, but more of a sort of maintenance program and moving forward program. So, you have to look at your client as unique.
Brilliant. Thanks, Jo. And just following on from that, what's your response when clients ask you how long it will take?
For how long is a piece of string is usually my answer. It really depends. Let's take James's client that's got endometriosis. If she's had it for 20 years, it's obviously pretty severe because they've done surgery on her. Then that's not going to improve overnight. It doesn't mean that she won't start to see improvement by running this program, doing a month. And actually, for some of my clients, I could run this program much longer term. It doesn't just have to be a month program. It could be something for James's client, he wants to look at doing for 4-6 months.
Yeah. Okay, fab. Thanks, Jo. Question come from Peter, who has asked, would progesterone ever be considered for PCOS if there's estrogen-progesterone imbalance? And he says, I do note the potential effects of progesterone on fibroids.
Yeah, do you know what? I mean, there are people who practice in bioidentical hormones. Obviously, as nutritional therapists, we're not allowed to. I just mention them because, people can buy them over the internet, and I've had many people think that progesterone, bioidentical progesterone is a quick way to lose weight. It's not at all, and it can cause other problems. But in some individuals, they notice it reduces water retention, that's all. But then you've got to look at the driver of why they've got the water retention. I know there are some great doctors that do, in London, that do practice in bioidentical hormones, but it's not something that I would, at this stage, advise that you went out there and did. You've only got to look at it at individual basis. And I think, I've sent a couple of clients with bioidentical hormones, and one of them it was somebody that went into early menopause, and there was no other driver behind it, and she started to show FSH went up, and she was only 28. So for her, bioidentical hormones was a good intervention. But no, Peter, for these conditions, none of them would be ones that I would go in there and use progesterone for.
Okay, thanks, Jo. And there was just a question, it was just following on from just the previous kind of discussion, is would only a month make a notable difference? But I guess, again, it depends.
Remember, what we're doing is not just using supplements during this month. We're making lifestyle changes. We're making dietary changes. Now, for some of you, this diet might not have been so different to what you normally eat. I know for myself, it's not that different to what I eat the rest of the months in the year. Although, to be fair, I seem to spend my whole life either doing one program or another to support our delegates through them, so maybe that's why it's no different. But for some of you, maybe it has. Maybe it's been a drastic change. And if you think about what you've had to give up to come on this program, and now think about your clients and your clients' diet. So, if they went gluten-free, if they revved up their antioxidants because we've revved up, vegetable salads, fruits, etc., if they cut out the stimulants, if they actually in a month, I think that they will start to notice a difference. Maybe it's not enough to break down the endometrial tissue, but maybe it is enough to start to feel the benefits. And remember, when people start to feel better, they don't want to go back to how they felt before, and therefore they're happier to continue to make these changes. So when people say to me, how long is this going to take? I say, right, let's just take it one step at a time. So for the first month, this is what we're going to do. And then I'm going to bring you back after a month. I'm going to repeat your statistics. I'm going to do your, in my office, I do BIA. So I'll repeat their BIA. I'll repeat their waist to hip. I'll repeat their BMI. Look at, changes that they've made and look at how they're feeling from a symptom point of view. And then I thresh out my client and go, right, you're feeling this much better. How much more are you prepared to do? And they might turn around and go, well, Jo, I don't want to go back to how I felt. So, bring on the next step. So it might be that then I continue with this program, or I adapt it slightly, or I add something in. And, that's how I would advise that you go forward. Don't ever, tell your client, oh, you're going to feel, absolutely cured in a month, because, that's not realistic. But I think it is realistic that we can make people start to feel better in a month.
Yeah, brilliant. Thanks, Jo. There's just one final question. I've left this one till the end because it actually relates to last week's webinar, if we can just kind of go back to what we were talking about last week. At the end of the webinar last week, you mentioned that you did a SNP profile for a baby boy of 8 months with eczema. And a couple of people have wanted to know, was it a profile, was it an individual SNP, and how did you support the baby, which supplements? I don't know if...
Okay, so I did a genome detox profile, which showed me that he'd got an absent GSTM1, and he'd got a single variant on his GSTP1. He's got catechol O methyltransferase. He's got a double variant, an SOD2, and he'd got, from memory, a 1B1 polymorphism, and also one of the ones with regards to metabolizing medications, but that's left. I don't know where it is because obviously I don't have the results out in front of me. I then did an immuno profile, and he's got a interleukin 10, which predisposes you. I'm doing this from memory, so just bear with me if I get these wrong. Interleukin 10, I'm sure, which predisposes him to atopic conditions, and he's got another couple of interleukins. Maybe, if I don't know how packed next week's webinar, maybe I can just quickly show you those results, or maybe I can do it on Facebook. Just depends
Yeah,
if I can keep it. Yeah, let me just see if I can keep it secure on Facebook. What I did has actually dietary-wise, he was on an organic diet already, he'd been weaned on an organic diet, and he hadn't been weaned on dairy. So all these were, away from that, but it did significantly get worse when he was introduced to food, so not when he was being breastfed. So although you might first of all think, well, it's the foods he's eating, I'm not disputing that. Remember, you can't do intolerance tests under 18 months of age. But what it could also be is mum's antibodies were keeping these conditions at bay. So then what I did is I used a combination of Alice-C to get the quercetin, the vitamin C in there, just open capsules up, crush capsules, mum was prepared to do anything. I used 2 non-nutri products, which I'll tell you about again, and I used a 4th product, I can't remember. Oh, Eskimo, duh. So I used Eskimo oil, and then I used liposomal glutathione, liquid liposomal glutathione, and then I used an I would have used Nutrimonium with him, but I was no way I was going to get much powder into him. And also calms the immune response back down. So I use those 4 products. And again, if I can get the before and after shots out there, I know there's a couple of people listening to today's webinar that actually saw them at the weekend, a couple of my students. The before and after shots are just amazing. And it was 10 days. Within 10 days, he went from looking like he'd been in a fire to looking like a little boy.
That's brilliant. Thank you, Jo. And just following on from that as well, there's been a question, are there any books that you would recommend to get a more detailed understanding of SNPs and genetic profiling? People who are kind of just starting out with it.
Yeah, take a look at the work from the Institute for Functional Medicine. There's quite a bit about it in the IFM textbook. There's not a book at the moment that says this SNP and this is what you do, and this SNP and this is what you do. Maybe I need to write it. Shall I write it? You'll have to give me a few weeks though, guys. So take a look at the work from the Institute for Functional Medicine. Take a look at the company. So like Genova run a 2-day course on genetic SNPs. And then once you've been on that 2-day course, then you can do the tests yourself. Until then, you're not meant to do the test because, of course, you don't know how to interpret the results. So I believe that they're running another one in October time or something like that. But give them a call.
That's fab. Thank you very much, Jo. So I think that's it for all the questions. Obviously, if anyone comes up with any more, you can either ring us in the office or post them onto Facebook. So yeah, thanks very much for joining us. Next webinar will be Tuesday the 27th of May, so a couple of weeks away, yeah. It's a Tuesday, it's 10 a.m. as usual, and you will be emailed all of the login details, and you'll receive all the follow-up and the recording, today's recording as well. So thanks very much, and we'll see you all